Hello, I'm Dr. Andy Pruitt, a sports medicine consultant. 25 years ago, I coined the phrase sprained knee. That phrase now is ubiquitous, even shows up in medical textbooks. Sprained knee comes from several common occurrences, such as too much volume too soon, combining the weight room with too much volume, or that crazy spring day, 70 degrees, and you jump into that big group ride with your shorts and don't protect your knee.
Welcome to Fast Talk Laboratories, your source for the science of endurance performance.
So the human knee is definitely an imperfect lever. You know, if we think about the perfect lever system, the block and tackle system, if that's the way our knee was designed, it would be a great transfer of power, be a very efficient transfer of power from the human to the bicycle. Sadly, the human knee is not a perfect lever system. It is designed for activities of daily living. It is designed for uneven ground. It's designed to rotate. Plus, it's made of muscle, tendon, cartilage, bone, all of these living structures, far from a perfect lever system. Knee injuries can occur for a lot of reasons, right? Even if you're a biomechanical 10, you can still get a knee injury. Think about it. If you're a big, strong rider, you can lay down so much power that you can actually acquire patella tendonitis, quadriceps tendonitis, patellofemoral dysfunction. Don't get hung up on the big terms. We're going to come back and talk about that. But if you're one of the regular people that's not a biomechanical 10, and you've got some kind of rotational instability or lateral instability or a malalignment, then your chances of a knee injury are definitely on the increase. But think about this. If the knee is the most common injured body part from cycling, why is cycling the most common prescribed rehabilitation exercise for the knee? Because when the bike is fit perfectly, it can be very friendly to the knee. But again, biomechanical 10, lay down big power, even pro tour guys can get tendonitis. The big offender, however, is that mal-fit bicycle, right? So let's think about injuries in two groups. There's intrinsic injuries and extrinsic injuries. Intrinsic means you have an anatomical variant or biomechanical malalignment that lends you toward these injuries. The extrinsic injury, however, is a training error or that mal-fit bicycle. When you take them and combine them, what you've got is disaster. Intrinsic plus extrinsic leads you to a disaster. Anterior knee pain, spring knee, front of the knee, however we want to describe it today. It's patellofemoral dysfunction, and it comes in a lot of different variations. The term chondromalacia. If you've ever been to the doctor for knee pain, they've probably told you you had chondromalacia. Chondromalacia is a term that means degenerative cartilage or cartilage inflammation. You can have chondromalacia in your TMJ, your shoulder, your ankle, but when you talk about chondromalacia generically to a sports medicine doc, he's really talking about the patellofemoral joint or the front of your knee. In this slide, this is a right knee seen from the front view. The quadriceps tendon and the patella tendon are called out. The quadriceps tendon, think about it's the transmission in this car. The muscle is the motor and the tendons are the transmission. So the quadriceps tendon is really attaching your big, powerful quadricep to the top of your patella. The patella tendon runs from the tip of your patella down to your shin bone. In the blow up at the bottom of this slide, you see some hemorrhagic change, some bloody change, some small micro tearing, if you will, at the tip of the patella as it inserts into the patella tendon. This is the most common place for patella tendonitis to occur. I'll show you why. So this slide is called patella tracking. It's a side view of a right knee shot from the inside. And it goes from a straight knee on the left to a fully bent knee on the right. You can see two things happening. One, the contact patch, where the back of the patella actually contacts the front of the thigh bone, the femur, increases with flexion. The more it bends, the more contact there actually is between the kneecap and the thigh bone. So that as that contact patch increases, so does the velocity of that compressive forces. So that's one type of knee injury, right? Too much pressure from the knee bend. The other is, if you think about an old-fashioned coat hanger that you bend and bend and bend that it ultimately breaks, then think about the patella tendon at the very tip of your kneecap, that coat hanger bending. You forget to put on the right shorts that day. There's 3 millimeters of tissue between the cold air and your patella tendon. It gets brittle, bend, 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 boom, the coat hanger begins to fray. This x-ray shows what's called a merchant x-ray. Old Dr. Merchant, I'm sure, named this thing. But if you think about you're sitting like I am on a bar stool, and I'm just knees bent looking down through my knee, that's what the merchant view looks like. So if we were to draw it, femur, patella, right? That's what you see on the merchant view. Now, some really cool stuff about joints. The front of the thigh bone in the joint has a layer, and the back of the kneecap has a layer. In a perfect knee, the back of the kneecap and the front of the thigh bone have a virtually zero drag coefficient, right? They're so slick. It's like wet ice on wet ice, drag coefficient of 0. But what happens if things aren't perfect? Articular cartilage is made up of pillars of collagen. Think about baffles in a waterbed, or however you want to think about this. So these are pillars of collagen. And inside around the pillars of collagen is a matrix of fluid, kind of like white Karo syrup or peanut butter, if you will. And the key is that all the ions in that fluid are negatively charged. So this is a captive system of fluid and pillars, all negatively charged. So what do we know about when all the charges are similar? They repel each other, right? So that's what gives articular cartilage its life, is this fluid repelling each other and the pillars of collagen. If, for one reason or another, that membrane is violated, the fluid's going to leak out, and these pillars of collagen then are exposed. If you think about when you move your knee, if you've got a little grinding noise, it's typically because some of these fibers are now exposed, looks like shag carpeting blowing in the wind, and they rub against each other, and we've lost our 0 drag coefficient, and now we have a little grind or a little drag. If on the left knee on the x-ray, the kneecap is shifted significantly to the outside, and suddenly here is where the kneecap is, and this not only is the drag coefficient 0, but the compressive forces increase exponentially. So sprained knee is primarily anterior or frontal knee pain, but it's very often it begins to migrate more to the inside of the knee. So it's going to call it anterior medial knee pain. But to really learn the structures of the medial knee, we need to talk about some fancy words: medial retinaculum, plica, medial patellofemoral ligament, and pes anserine tendinitis or bursitis. We'll cover them all, and we won't get too hung up on, making you anatomy majors. So here's your old slide again. You've seen this before, where the quad tendon and the patella tendon were both called out. Now there's a marker on the medial retinaculum. If you really look at this structure, it's those guy wires we talked about flaring down from the patella, moving off onto the thigh bone. So they're really, right here. This is the medial retinaculum. So here's our merchant x-ray. There's our patella. There's the medial retinaculum. And there's where it inserts onto the patella. And this is the weak link. Now, if we look at this slide, it's really a surgical slide. It's from the arthroscope. You can see the camera looking this way toward this wall, and there's a band of tissue that are obviously different, more bold, more sturdy than the rest of it. And that's called the medial patellofemoral ligament. Funny sidebar, one of my early mentors in sports medicine, Jim Holmes, orthopedic surgeon in Denver, he and I were partners at the time, and this is when black look pedals came into play, and there were a lot of equipment changes. And this particular injury became epidemic. And we were actually trying to solve it. So he, as a surgeon, said, well, I know how to solve it. I'll just cut the sucker. And so we actually wrote a paper about it. We were going to name it the ligament of Pruitt and Holmes. Then we found out it actually had a boring name, the medial patellofemoral ligament. It had been much more exciting if it was the ligament of Pruitt and Holmes. But now maybe you'll remember that this retinaculum over here, there's a band in it that is more bold than the rest of it. 70% of all humans have this call-out sturdy band in that medial retinaculum, which makes them, more prone to having this insertional injury on the medial edge of the kneecap. I actually, at a Pro Tour race, examined every knee in the peloton, and again, 70%, I think it was 72% in that particular group, had this particular ligament. 3 people dropped out of the race that year because of this insertional ligament. So now this slide really shows the whole retinaculum, this broad sweep of support from the kneecap onto the femur. And you can see how it could be injured, especially with a malalignment. So the plica band is an embryological remnant that many people have, and is nothing more than a wrinkle in this retinaculum. So if you see this wrinkle that kind of inserts itself into the patellofemoral joint or joint space, and these compressive forces begin to pinch down on this wrinkle, it can become quite inflamed. So in the early days of all the new fancy equipment, we were cutting medial patellofemoral ligaments. We were going through the arthroscope and extracting this out. The guys that didn't know much about endurance sport, the surgeons that didn't know much about endurance sports, were going, oh, they've got terminal plica disease. Every cyclist is having their plica excised. Well, when bike fit became better and equipment became better, this disease has actually pretty much rid itself. It's one of those things where science has caught up with development of the sport, and we don't see as much plica inflammation as we used to. We definitely still see the medial retinacular stuff along the inside of the knee as well. So we're starting to think about these combined pathologies, right? Where since spring knee, we talk about this anterior knee pain in the front, but it starts to migrate toward the medial side. So we're really starting to learn about those medial structures, the retinaculum, the plica, etc. So what happens when we mix these things all together? We've got our quad tendon and our patella tendon and our compressive forces, right? So if we move just a little bit medial, we've got the retinaculum, the connective tissue which binds the patella, like the guy wires of the big top tent. Sometimes you'll even have this one be really strong, and it's going to be the medial patellofemoral ligament, or even then you can have the wrinkle back there, and there comes the plica. There's a combination of tension under these, compression under the plica. This structure, this blue structure, is this green structure over here, and it's this insertional area on the patella which gets sore, and the plica that gets compressed. Hopefully that's combining the two views can kind of get you to understand how we move from pure anterior knee pain to anterior medial knee pain. If we go farther medial, right? So this is a right knee from the inside, going that way. There are 3 hamstring tendons that attach down here and swoop up and actually connect on the pelvis, called the pes anserine. That's Latin for goose's foot. If you look at a goose's foot, it's got 3 bars. We've got 3 tendons that swoop up. They all ultimately conjoin into one and become one of the medial hamstrings. Pure medial pain. This is not anterior or anterior medial, this is pure medial. It occurs on the inside of your knee, and there's a bursa. Okay, what the heck is a bursa? A bursa is a structure that will appear anywhere in the body where there's pressure or friction. One of the common bursitises for cyclists are the sit bones. We get an ischial sit bone bursa that it's going to occur from sitting on a saddle too long. It can occur at the elbow. Any place where there's friction or pressure, a bursa sac will appear. You can see on the slide there's a little blue bubble under these 3 tendons that have been cut away. That is the bursa. So think about this knee. Bend, 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 bend. The bursa is doing its job. It's helping lubricate friction. If it becomes over irritated, suddenly, instead of being this thin, greasy thing that does lubrication, the bursa will actually thicken and become opaque, more like a jelly, and it actually becomes fibrotic, and you get a bursitis. So yes, you can get a tendinitis early season in the tendons themselves, but more likely it's a bursitis that's going to occur. It's rarely an injury that occurs from the extrinsic values, right? So the rider error, that kind of stuff. It's usually an intrinsic injury, meaning that you're too knock-kneed. So the more valgus or knock-kneed you are, the knee's going to come this direction, placing these guys under greater stress and placing that bursa under greater friction, right? So that's pure medial knee pain. So we've talked about typical spring knee being the front of the knee, and sometimes it migrates to the medial or the inside of the knee. There are occasions where we do get lateral knee pain in the spring, but most of the time, lateral knee pain is a mid or later season issue. The structures on the lateral part of the knee that we're going to talk about are the iliotibial band. You know, if you're a cyclist, you know somebody that's had iliotibial band issues, or you've had iliotibial band issues, or you've had lateral knee pain and didn't know you had iliotibial band issues. On the lateral side, you can also get some pressure behind the kneecap laterally in the retinaculum that's similar to the medial side. But the real lateral knee pains are going to be the iliotibial band and the biceps femoris, which is another hamstring attachment, but it's on the lateral or the outside of the knee. Iliotibial band friction or traction syndrome, at one point in time, it was an epidemic in cycling. And it's one of those injuries that we learned about because the change in technology, typically the floatless binding cleat that came into play in 1985, really set off an epidemic of iliotibial band issues. I could go into a long oration about how the pedal changed and the competition of the pedal companies and one guy jumping over to another company to solve the epidemic in iliotibial bands. But my partner Jim Holmes and I really were inundated by cyclists from all over the world with this issue. So we actually developed a surgical technique to relieve people of iliotibial band friction syndrome. Quite successful. People came from all over the world. But as fit got better and as the pedal systems got better, the incident of iliotibial band issues decreased. This new slide is the lateral or outside aspect of the right knee. So the patella is to your right, the back of the knee is to your left. You see two transected tendons. The little one is the biceps femoris tendon. It goes from the head of the fibula all the way up to the pelvis, is one of the hamstrings. It can become an issue on the bike, especially if there's too much float in your pedal system. The biceps can become an issue, but the true lateral knee pain that's either going to be, not so much in the spring, like I said, it's going to be more of a mid-season, late season issue, comes at that pure lateral aspect of the knee. You see the little blue bursa there that's showing up under the iliotibial band, which has been transected. Now, is the iliotibial band a ligament? Is it a tendon? Can it be stretched? Can it not be stretched? These are all controversial things that are in the orthopedic and physical therapy literature right now. I would tell you that I don't think it can be stretched. I could quote a study for you where they took a cadaver iliotibial band, hung a 500-pound weight on it in the lab, and it took weeks for it to fail. It did not stretch. But, however, if somebody prescribes stretching for you for your iliotibial band issues, do it, because I have seen it have a high rate of success. Whether you're stretching your quad or they're truly stretching the iliotibial band, you don't really know, but stretching can be a solution for this problem. Again, turning back to the slide, we've got the bursa that we see. Frictional bursitis is the most common kind of iliotibial band friction syndrome. We actually, in the early days, invented a surgical technique to cut a window in that band to make the bursa be frictionless, if you will. In that process, we actually learned that there's two kinds of iliotibial band. And we would go in, we'd cut this window, and the athlete would come back and say, well, now it hurts just above my knee. Well, here's the deal. This is a pelvis. The athlete's looking at you. This knee is in valgus, which is a knock knee. This knee is more straight or slightly bowed, right? So the iliotibial band runs from the iliac, which is the crest of the pelvis, iliac, clear down to the tibia, which is the shin bone. It crosses two joints. It crosses the hip and it crosses the lateral knee. So friction is going to occur in this knee, which is either very straight or slightly bowed. You see where if I bow it out, I'm going to put friction there. On this side, however, the knee is naturally inboard, and one of the purposes of the iliotibial band is a lateral stabilizer. So there are little spot welds of insertion of the iliotibial band along the lateral femur. If you've ever rolled on a foam roller for your iliotibial band, and as you roll up your thigh, you're going, whoa, wow, what are these lumps? This is so painful. You're rolling over these little spot welds, if you will, along the lateral femur. This is trying to keep the knee from collapsing inward. So we go in there, mistakenly cut a window to make the bursa frictionless, but that wasn't the issue for this character. He really has a tractional injury right where those little spot welds attach along the lateral thigh. So this is iliotibial band friction bursitis. This is iliotibial band traction syndrome. It takes a very discerning set of diagnostic hands in the clinic to figure out which is which. If the biomechanics are obvious, this knee is valgus or knock knee, it's most likely going to be a traction injury. If this knee has normal anatomy or slightly bowed, it's going to be a frictional injury. Now, bike fit can change your diagnosis, because if I take a bow-legged guy and make his stance width too narrow, I increase the traction. If I widen this guy's stance out, I relieve his iliotibial band. If I widen this guy's stance out, it increases his traction syndrome. So the generic solution for lateral pain is to widen the stance, because most of it is friction. But if you've got one of those less common tractional injuries, widening the stance is going to make it worse. This slide really shows the friction point. So this slide shows the, again, right knee from the lateral view. There's a big white marker that's pointing out the prominence on the lateral knee. The iliotibial band is in front of that friction point when the knee is straight, and it's behind that friction point when the knee is bent 90 degrees. So every time your knee passes 90 degrees, you cause the friction on that bursa. This slide is very, very pictorial. It really tells the story quite nicely. This slide actually shows the window in the iliotibial band that we used to cut to make it frictionless. But I like this slide because it really shows the thickness and the width of the iliotibial band as it passes that lateral knee, and how big that window was that we used to cut into it. So, haven't said it enough today, bike fit is the solution to most of these issues, unless it was user error, right? Posterior knee, the back of the knee, is the least common area for cycling injuries. Now, there are a couple pedal systems out there that have a lot of float in them, and there's a rotational stabilizer in the back of the knee called the popliteus tendon that is kind of a sway bar. If you use car technology, it keeps the knee from rotating. So if your pedal system has too much float, it's like walking on ice. Your popliteus tendon deep in the back of the knee can be tender. And again, it takes a very astute pair of diagnostic hands to find the popliteus tendon. It's usually found on MRI. The more common posterior injuries are hamstring tendonitis or gastroc or calf tendonitis. So this slide really shows the back of the leg. So it's obviously a right leg again, fully muscled, but skinned. So you can see your glutes up high, your iliotibial band, the big white structure coming down the outside on the right, and then your three hamstrings are split. So the pes anserine are those three tendons we talked about on the medial knee. The biceps femoris is the single hamstring tendon we see attaching to the fibular head on the out. They kind of, you see how they split and go around. The gastroc comes inside of them. It has two separate heads as well. So the gastroc, or your calf muscle, is going to split and go up and attach underneath those hamstring tendons. So this is really, I've never known of a posterior injury not being bike fit related. Typically pedal system choice or saddle height being the solution to these guys. You know, like bike fit is really the number one solution to most of these things. Occasionally a cortisone injection for that really chronic, habitual, reoccurring tendinitis or bursitis. Cortisone can be a truly magic drug. I know there's some stigmas around cortisone and abuse of it, but in the judicious use of cortisone in the right hands and in the right anatomical structure, it can actually be a miracle. Physical therapy, you know, cycling right now is so popular that there are physical therapy clinics that really do specialize in endurance sport, both running, triathlon, and of course cycling. And the really, you know, astute physical therapist understanding cycling biomechanics can really play a big role in your as you chase down your spring knee or your summer knee, since we've drifted into that summer season in this discussion. So hopefully today we've given you enough information that you can maybe self-diagnose your injury, or scare you enough that you'll seek some professional medical attention. Thanks for joining me today on our presentation on spring knee. We did drift a little bit into the summer knee and the posterior aspect, but mostly spring knee. Hope you learned something. Thanks very much for being a member of Fast Talk Laboratories. I'm Dr. Andy Pruitt, and I'll see you next time.